welcome to our AGM. I'm Anne Rainsberry, I'm the acting chair for South West London ICB. And today is the AGM for the year that's just passed, so 24-25, and it's an opportunity for us to tell you our own reflections on the year, what's been achieved, the challenges, etc. But also for an opportunity for people to ask questions about some of the things that mean something to them about the health services within South West London. The AGM is being broadcast and will be available for people to review, so just be aware that it is being recorded, and if there's any issues with that, there's a conference team at the back who can give you further information. Practicalities in terms of the housekeeping. Now, we're not expecting a fire alarm, but if there was a fire alarm, you can see, I think it's here, is where we would go out and we would, it doesn't say where we, go to the forecourts near the care homes. The care home's just over here, if there is a fire alarm, but say we're not expecting one. If you need the toilets, they're out of this door and to the right if you haven't found them. And if anybody needs a hearing loop, then please let us know. There is one available, so we can just make sure that you have access to that. Now, as I said earlier, there will be an opportunity for you to ask questions. And I know some people online have also submitted some questions, but we're dealing with that after the presentations, but we will have an opportunity to do that. And last but not least, we're hoping that everybody's signed in. If you haven't, there's a desk at the back. Please do, because we'll make sure that you have access to the recording after the event. So if you haven't done so, please do. So, in terms of what we're hoping to cover, the Wi-Fi. So hopefully people have found the Wi-Fi, but there are the details if you want to log your phone onto that. Now, as I said, today's meeting is covering the year April 24 to March 25. You'll be able to read our annual report, and this covers the financial position on our website. And there's a QR code, which was on the previous. I'll just put that back in case anybody wants to take a photo of it. But you can get the annual report from our website as well, so you can read through that. Can I introduce the really important people here today who's going to tell us about what we've achieved during the last year. So first of all, Katie Fisher, who's our Chief Executive, so first AGM for South West London. Then we have Helen Jameson, Chief Finance Officer for the ICB, and then Elaine Clancy, who is the Chief Nursing Officer. Other members of our board are in the room, so could I just ask anybody who is a board member just to put their hands in the air so people can see them, so you can seek them out and ask questions if you would like to. So I think that's all in terms of introduction. In terms of what we're going to cover then, we're going to start with a look back on the financial position and the achievements in the annual accounts, and Helen's going to take us through that. We're then going to talk about the 10-year plan. Obviously, that has been published during the last year, and within South West London, we've been doing some work and thinking about what that can mean for how we want to improve health services for the population we serve. Then we want to talk about the clinically led strategic plan for South West London, and Elaine's going to take us through that. And as I say, that there'll be an opportunity for questions after we've had those presentations. So I think that's all I'm going to say, and I'm going to hand over to you, Helen.
So thank you, Anne. So it gives me great pleasure to talk about some of the achievements that we managed to deliver for the South West London population over 2024-25, and also to look at how the money was spent to enable us to do that. So if we just start thinking about why ICBs were created in July 2022, it was really about bringing the NHS and partners together to be able to deliver and improve the health and well-being of our population, to really be able to open up access to our services and to improve the patient experience as we go forwards. And that is at the heart of what we've been doing since we started out as an ICB in July 22, and what we've continued to do over the coming year of 24-25 and 25-26. Although we recognise that nationally there have been many announcements in the last few months about the roles of ICBs, how we go forwards, and that will be changing and evolving as we go in order to help us and support us deliver the 10-year plan. But at the moment we continue on this journey of where we are and what we're delivering, and that's the highlights I'd like to take you through today. Some really key parts of that is really thinking about how we embrace the 3 shifts that have been spoken about. So how we take care from our acute providers and into our community and closer to home. How we look at sort of treating sickness and move to prevention, and how we really embrace digital in what we do as we go forwards. And those have been key things of what we've tried to do while we've been delivering things in 24-25. So if I look back at the performance from the year, we did really, really well against our key NHS targets and in delivering against urgent and emergency care, about supporting cancer and delivering GP access, and really focused on how could we reduce waiting times as we go forwards. We've done a number of things to try and do that. We've really tried to embrace technology, so we've used that in our dermatology pathways out in Epsom. We've really looked about how in our emergency departments we can use digital to help speed up that process to see patients admitted and what we can do and help support them. And we've also looked about how we can use AI and other sorts of methodologies in outpatients as well. So really trying to drive that forward, and you'll see when I get to the financial section how we've managed to really increase activity in some of those areas to be able to support more appointments for patients. So if we look forward as we continue to go and we look at those 3 shifts, a key part of that has been about strengthening neighbourhood care. So we look at how have we been able to start to develop those neighbourhood teams as we go forward to really bring GPs and community services, social care and the voluntary sector together. Because this isn't just about health, it's about how we work together in that partnership. Sutton has been highlighted as a great example for London about the work it's done on prevention to date. And we've really looked ahead about what we want to do. And there's been a national bidding process to put 43 pilots in place, and we're really pleased to say that Croydon was successful in that process. So we continue to push forwards to really localise care and make it closer to home. So key to all of this is prevention. How do we prevent the illness in the first place? And we've really looked to see what we can do and where we can invest to try and improve that. Some of our key successes are here on this slide, but just to call out around the NHS type 2 diabetes pathway, really managing to help over 500 residents to lose over an average of 10 kilograms each, to really help them change their lives and their risk profiles. So we go forwards. Obviously, vaccinations have been at the heart of what we've done for many, many years, and we continue to focus on them. And then we've really taken an active part in the cardiovascular health, looking at the London's Million Health Hearts and Minds campaign and how we can help and support those. And finally, looking at smoking cessation and how we've really managed to help 6,000 hospital patients to really support them on the tobacco dependency programme. So we've done this through digital, and we're really, really proud of this part. We've had such an amazing take-up of the NHS app in South West London, greater than many other parts of the country, with almost 1 million people there actually logging on. I think that's got to be our target to exceed and go forwards. To really help and support residents get access to things to be able to help their own care through the digital tools that are available, such as Get You Better app. And really help people use digital so that we can take that time away from our clinical professionals and they can really focus on the care that will make a difference for the patients and the population. We've continued our work on our Wi-Fi upgrades in our community and primary care sector, and you'll see that in the finance section as well. It's been an ongoing programme of work that we really want to put the infrastructure in place, so as the technology comes along, we're already ready for it. And finally, we can't do that without our communities. How do we work with you? How do you tell us what you need? How do we really manage to drive that forwards, understanding what it is that will make a difference for all of you? Our Winter Engagement Fund has been really key to that, managing to reach out to over 10,000 people to go forwards to really understand what would make a difference for South West London residents. Really helping to support things through the NHS app and Pharmacy First to be able to take things forwards and make those conversations right. And what we've tried to do, because it's difficult to do this and engage with everybody, is really create that insights bank so that we know when we can learn, and when different programs of work are going on, we can access that information and intel you've already given us so that we can take that forwards and drive it through. So for us, it's really, really important that that ongoing conversation continues to be able to drive through what we do as we go forwards. So that's what we've managed to do, and that's what we've managed to deliver. So how did we spend the money while we were doing that? Where did we put the money to make a difference? So we need to make sure we follow the correct audit rules to make sure that we get value for money and how we spend. And I'm really, really pleased that when the auditors looked through our accounts for the year, they gave us a true and fair view and told us that we'd spent appropriately and invested in the right way and met our targets. But where was that money spent? Well, as an ICB, as an organisation, as a commissioner, we received just over £3.7 billion funding in 24-25. We used that to help the whole population of South West London, whether that was spending within South West London or spending at providers outside of South West London to give care to our residents, of which we spent about 79% of our total acute spend in sector. So you can see a lot of it is done within the hospitals within the South West London footprint. And we spent about 106 million on planned care. So where you went for your planned operation to help and support you to go through. So that is a lot. There's then also spent around community, around GP, and about the urgent care pathway. So what did that buy us? I said a little bit earlier about the activity that we'd done. You can see if you look here in the two tables that actually all the activity we managed to deliver in 24-25 was greater than 2023-24. Both our urgent care and A&E attendances increased by about 5% each. On our planned care activity, our operations increased by about 7%, where outpatients attendances increased by about 16%. So our trusts and healthcare providers really tried to up their game to deliver more within the pound that they had. Over and above that, our primary care services, it always astounds me when I look at this every year, £8.7 million appointments. It's massive, huge in what is delivered for our community. And that increase has mainly been in online. So it's about using technology and embracing it, about how we can deliver more for our population. So I think it's really, really important to understand the different types of care that we buy, but the fact that we are continuing to deliver more from within the pound that we have and trying to really stretch that and drive that forward, whether that be around CHC packages or the mental health investments that we've made as we try to drive things forward. So just another part of what we spent our money on to give you a flavour of not just that planned care or urgent and emergency care pathway. We've invested £27 million with the Cancer Alliance to really help and support the population and transform cancer services over the last year, whilst actually looking at our community pharmacists and look at Pharmacists First to really progress the pilot forwards as it's gone forwards with another £3 million. We've continued investing in community-based sickle cell diseases and renal replacement services to really drive stuff forward with the support of St George's Hospital. And then one of the key things, and this is one of the leading programs in the country that is recognised worldwide, is we continue to invest in the HIV and Hep B and C testing in emergency departments, which has made a significant change to the population that have been tested and detected so that they can have care packages put in place with them. That is being looked at worldwide about how that could be taken forward in other countries and what we've done. And so we're really proud to be part of that London initiative. Finally, we've got increased investment into mental health services through what we call the MHIS of 20.4 million in year, which has really helped work to improve the quality of care and to improve access into those services. So that's what we spent as an ICB on the population of South West London. But what did we spend as an ICS, which is the healthcare partners, so the hospitals, the community services, etc., plus the ICB itself? Well, that's actually over £6 billion now that we really invested and delivered services for within South West London. You can see within the envelope that we were given, we effectively spent all of it on delivering those services, which is really important that we make those pounds count. You can see here the split of the different organisations that were spending that money and what they were doing and what it looked like and how those services were delivered. Also, as well as spending money about delivering services, we look at what we can invest to improve our infrastructure, whether that be digital or estate. In 2024-25, we spent £164 million, of which 70% was about improving the state of our infrastructure, whether that's about replacing equipment, improving and maintaining buildings, or looking at more digital solutions and replacements for the infrastructure that is there. Some of the key things that we spend that on and real investments to make a difference for our population included the implementation of the new electronic patient record at Epsom and St Helier. We did a redevelopment, and we've started the redevelopment of the Barnes site for mental health services, which is due to go live in summer 26. We've really looked at the green agenda and net zero, and we've really tried to take funding where possible and looked for grants to be able to improve energy efficiency, etc. And there's some good things that we've done around LED lighting across all our hospitals. And we've really looked about how we can invest and build in primary care and community services. And we have some grants that are awarded previously that have now enabled a new site at New Addington to be delivered and opening shortly. And then also a site at Coulsdon, which is in development at the moment. So really trying to look at all the different parts, the different services that deliver across South West London to help and support the health and well-being of the population. So if I look forward into 25-26, we can see that we continue to be in financially difficult times and that we continue to try and make best use of every pound that we have. So we continue to try and balance our books and to deliver the plans that are set for us within the NHS guidance. We are really focusing on the efficiencies and improved productivity that we need to deliver this, but quite key as we go forwards, we'll be looking at our clinical strategy, about how best we can deliver services to get better outcomes for patients, to give them a better experience in a financially sustainable way. And Elaine will talk to you more about that. We'll continue to invest in our community and try and address the illness agenda to put more into prevention, and we will continue to look about how digital can enable us in all of this whilst delivering the 10-year plan. So big challenges ahead, but I think we've had some great achievements to date. So thank you for your time. I'll hand over to Katie.
Thank you very much, Helen, and thank you for stepping in. I think it's always much more important that someone who was actually here in the year was able to really talk about the highlights from that year. So as Anne said, I'm Katie, my first AGM with you. It's a real pleasure to be here with you this afternoon. Thank you for your interest in hearing not only about 24-25, but also our ambitions really to do the very, very best for South West Londoners moving forward. Helen has stolen a little bit of my thunder, but I was going to talk to you a little bit about the 10-year plan. But as you can see, we are as one in terms of how we're thinking. But I know a number of you will have got quite familiar with the 10-year plan, but it's important, particularly with the session Elaine's going to talk us through, which is, if you like, the South West London interpretation and application of the National 10-Year Health and Care Plan. So really importantly, for those of you who haven't read it, I would encourage you to do so, because it shows a really ambitious shift from a focus on health and health services to health and well-being, with a real focus around prevention and these 3 left shifts, which is incredibly important, particularly within the context of South West London, because, as Helen said, we have one of the biggest financial challenges of any system in the country. And to give you a sense of scale around that, really our underlying size of our challenge is about £500 million against those allocations, where for a number of reasons we are spending more money than we have allocated to us to meet all the health outcomes required for South West Londoners. So the 10-year plan really focuses on those 3 shifts, which Helen started to speak about. So first being hospital to community. Now, it's really important to make the distinction here, because just taking existing models from hospitals and putting them in the community doesn't actually achieve much in the way of benefit, but it's actually the neighbourhood element of working, where you actually have services working in a coordinated way around neighbourhoods where people live to meet the combined outcomes for a population. So the whole being greater than the sum of the parts, rather than just taking a consultant, moving them out of their hospital consulting room and putting them in a different consulting room in the community. This is a totally different idea and concept around how all of those services can come together to work with individuals, with the individual in charge. The individual, it's their life, their outcomes. How can health step in and support us all to stay healthy, to remain in control and feel we're able to make decisions about our health and our health outcomes. So that's that shift. The second is analog to digital. I'm conscious you don't want to make guesstimates about people aged, but there's lots of people in the room of a similar sort of age to me. But I have a house full of generation, I have to say Z. I know it doesn't sound so snappy, but Generation Z I can't quite get along with. But they will go to extreme lengths and significant personal inconvenience to avoid speaking to someone on the telephone. I'm seeing by some of your chuckles that you feel exactly the same. And so actually a lot of the only ways that people can access health and healthcare and health services is largely irrelevant to certainly some of the younger generation coming through. And actually, if we really want to focus on prevention, if we really want to equip South West Londoners to be able to stay in control and be responsible and lead their health and their outcomes and their interaction with health and care services, we really have to enable, not as a one-size-fits-nobody, but a real shift from analogue to digital to make sure that the NHS and how we interact with it is relevant for all of us, for whatever life stage or generation that we're at. And the third is this sickness to prevention piece. I think if all of us had meaningful tools that we could engage with and understand and become relevant to us at the time when we need them, we would all want and feel able to do more to manage our own health, to remain healthy and prevent ourselves from getting ill and then having to receive treatment. So the challenge we've always had in a very politicised health service is actually how do you invest in long-term health improvement and population health. But there are a huge number of things that can be done, really, that actually describe pathways of care that start right at primary prevention. And it's our job as healthcare leaders across the system to make sure that every aspect of care, every aspect of services delivered starts right at the very beginning with primary prevention before we get into any part of actually healthcare service delivery. So as colleagues have pointed out, and I should say at this point that Charlotte would be talking to us at this point about the fantastic work that our community engagement team has led across our communities to make sure we got your views inputting into the national response to the 10-year plan. But the irony is not lost on any of us that she's lost her voice completely. So, I mean, literally no voice. So I will do my best to give an adequate reflection for what was a really extensive and really inspiring piece of work that was undertaken to respond to the national plan. And so what we did was from a variety of different aspects, workforce, community and partners. So extensive engagement across not only ICB and ICS staff, but across all of our providers, partner organisations, primary care, dentistry, optometry, pharmacy, to really try and engage and get views and perspectives specific to South West London to make sure there was that relevant input into the national 10-year plan. We also built on the Winter Engagement Fund, which I know many of you will know far more about than me, but the huge number of events, really wide reach, either with us directly or through voluntary sector organisations, reaching the communities that they serve and work in partnership with to make sure that your voices were heard and fed back in through the national consultation process. And then a huge amount of work done at place with our place-based teams and the alliances that they support and all of the community organisations they represent to make sure that we got a very specific South West London focus into that conversation. There's just an example, a couple of examples here. So when the government launched its engagement, we did some very, very big events here. So one of those was South London Listens. A number of you may have already been involved in that, but over 30 partners came together to share their views on the NHS 10-year plan, was hosted by our then ICB chair, Mike Bell, and with Citizens UK. Lots and lots of really lively and valuable conversations that really have helped to inform our ongoing work. And then the South West London Listening event. So over 80 voluntary sector, community and Health Watch partners joined us here for a really, really vibrant borough, place-based set of conversations, really to try and focus on local priorities to make sure that as we're driving our future planning, we are understanding what matters most to local communities. So moving on then from the 10-year plan, I'm not going to steal Elaine's thunder, and she's going to tell us how South West London are responding to the 10-year plan. But for those of you who might have been on holiday for a long period of time since March and maybe not heard, there's just a change or two afoot in terms of how the NHS is led and being managed moving forward. Indeed, 3 weeks into my appointment here at South West London ICB, the announcements of the Model ICB blueprint and of the biggest transformation and overhaul of NHS leadership across the abolition of NHS England, the merger of that organisation into the Department of Health and Social Care, the transformation of ICBs from the organisations you recognise now into what they will be as strategic commissioners into the future, arrived, as I say, 3 weeks after I arrived. So huge respect to the team. They've had to have a lot of patience with me. It was perhaps not quite the arrival they were expecting of their new chief executive. So what does that actually mean? Well, in terms of the nuts and bolts, the national policy is that a real shift to the front line, and actually provider organisations and their boards should be accountable for a greater proportion of the performance management, regulation and oversight of the services that they deliver. And that as an ICB, we would not be continuing with those kind of roles because it's felt to be duplicative, and therefore we would be focusing really very much on acting as a strategic commissioner. So therefore, really looking at the long-term population health needs, both from now into the long-term future, and making sure that we commission the right outcomes to deliver the very best possible outcomes for South West Londoners. So that takes place in sort of a cycle. So you may be familiar with this document. So what does strategic commissioning actually mean? And it's interesting as sort of like a bit of a vox pop. If you ask 10 different people, they might give you 10 different answers. So this is the kind of easy guide. So what does it mean? It's actually knowing your population really, really well, both looking at historical data, but also predictive data about what needs might look like, both now and into the longer term future. It's knowing that at a really granular neighbourhood level. So the trouble is, if you aggregate everything up to a South West London population, all averages mean is that you've got 50% of people above and 50% of people below. So it's really getting underneath the detail of that and understanding where are our local communities that have a higher level of need, and actually how is that need best met, and how can we make sure that we work with partners to make sure that we're providing service solutions that are responsive and able to support those particular communities in driving those improvements in population outcomes and experiences. So understanding the local context. South West London is not one great thing that everything's the same. We know we have hugely vibrant, diverse communities with very, very different priorities, very, very different needs, and a very different way of engaging with health and healthcare. So we need to respond to that. So developing the long-term population health strategy. This is spoiler alert. What Elaine's talking about is our long-term population health strategy for South West London, and the approach that we're taking to make sure that all of you and the communities that you are within have full opportunity to really engage and tell us what's most important to you as we work through this piece of work. The next is delivering the strategy through payer functions, and that's when this language gets a bit sort of less user-friendly. So what that means is that actually we will increasingly use the money that Helen has spoken about in a way to say to alliances of providers that work around neighbourhoods or multi-neighbourhoods, as we're calling them, to deliver particular outcomes. So we will less often in the future have a contract with an individual GP practice or an individual hospital or an individual hospice or an individual voluntary care organisation, but we will have a contract with a system of providers working together in an alliance to deliver a set of outcomes for a particular population. So hopefully that makes sense. So actually we're trying to join everything up. So rather than have contracts that we have at the moment where there are perverse incentives, a great example is actually in a hospital, A&E is incentivised to manage people through the A&E pathway as quickly as possibly. Great, you might say that's marvellous, but actually in a mental health environment, they're incentivised not to accept a patient until they have a bed. So those two things can quite often be in direct conflict with each other. And actually it's very difficult then to actually make decisions that are right for our citizens to deliver the right outcomes across the entirety of a pathway. So the point of these different ways of paying for services is to enable providers to work together to deliver consistent outcomes rather than this slightly clunky system that we have at the moment. And then really importantly, and something that the NHS doesn't do terribly well, is evaluating the impact. Rather than just saying, we're going to commission this, we're going to buy this service, and then sort of, cross our fingers and think, well, hopefully that'll work. Actually, we really, really scrutinise it very carefully right from the beginning. We collect the baseline information, we test what we think we want to achieve, and then we really, really make sure that we're measuring to say, have we done what we said we were going to do? Has it delivered what we wanted it to deliver? If not, why not? And how can we improve it? And we do that in a continuous cycle of improvement rather than wondering what happened when we just commissioned a service at some point down the line. So hopefully that makes sense, but it's a continuous cycle. Actually, there's a lot of really, really great skills we already have in the ICB that can help with this, but there are new skills that we're going to have to learn, particularly some of the data science, some of the sort of long-term needs assessment work that we will need to develop and grow some of that capability over time. So I think I've probably said enough on those, but Elaine's going to bring it to life for us. And I think the important thing to say is, as I say, South West Londoners have a right to expect more from us as healthcare leaders across our system. Therefore, we need to be on our A game to make sure we really, really understand needs both now and into the future. We use really robust evidence to allow us to do that. And really importantly, both communities, individual citizens, patients are at the heart of that decision making, but that it is clinically led by people who really understand and can assess the evidence of what good looks like and make sure that we give you the best possible pathways of care that we can, that we know are supported by good evidence and supported by our clinicians. So it's on that basis, with no apology, that I've asked Elaine to tell you in a bit more detail what we're up to and what stage we're at. So, Elaine.
Thank you, Katie. I'm delighted to be here today to share with you some of the exciting updates in terms of our clinically led plan. Unfortunately, the glasses need to go on and off because I can't read, but I can't see. I've got my glasses on, so the glasses will go on and off, I'm afraid. I'm too vain to say I'll wear glasses all the time and have bifocals. I think I'm too young. So, developing our clinically led strategic plan. It's a really, really exciting piece of work, and I'm really delighted to be part of it. We know that in South West London, we've got dedicated and excellent staff providing some really high quality services, but we also know that there's some areas that need to be improved for our local people, and that's what we want to do. People's health has changed, not just locally, nationally, people's health has changed since the NHS has been in place. and demand has also increased on what is already very stretched NHS services. The clinicians that I work with tell me that we can't continue to go down this same path, just making tweaks to a system that's creaking under the pressure. That's not right for our patients, and it's not right for our staff either. And I hear that every day when I'm out and about, that what we're doing isn't good enough, it's not right, we've got to, and we keep trying to make some differences, we're not making the differences that we need to do. So this is a really exciting opportunity to try and make that better. What we need is local clinical directors taking the national direction, and Katie's talked to us about the government's 10-year plan. I'm part of a great group of clinical leaders that will now take this direction and look at the evidence to find where the biggest opportunities are to make the change and improvements that are required. We need to understand and predict the health needs of our local population in South West London. We need to look at our clinical outcomes and compare that to national best practice. We need to look at the operational data that shows us how we are performing for the local people of South West London. We need the workforce intelligence to support our frontline clinicians to reshape the services and work in new ways and reshape the services that they and our patients and population tell us we need to. And we need the insights from the experience of the patients and the local population and the communities who want more control to manage their own health. So, developing our clinically led strategic plan. How do we do that? We need to focus on our inequalities and variation in services. We know that's too much. We know that many of you have told us that we have a diverse population in South West London, and we know that people in working class roles who are from ethnic minority backgrounds and live in particular postcodes, who may have experienced domestic violence and other challenges, may be homeless and have financial difficulties. The evidence tells us that they're likely to experience worse outcomes from the NHS, poorer access, and will often die younger. That cannot be right. We cannot have an NHS service that just serves certain communities. We've got to get it right for all of our population in South West London, and this gives us an opportunity to be able to change that. We need to change the variations and the inconsistencies in people's health outcomes. The NHS in South West London needs to work harder to tackle those inequalities in both access and the outcomes, to give everybody in South West London, no matter who they are or where they're from or where they live, the means to engage with the NHS in a way that works for them. That's ambitious, but that's what we're keen to do, and it's the right thing for us to do. How are we going to deliver this? As Katie's explained, once the clinical leaders have looked at all the evidence, we're looking at the technology possibilities and how we can improve on our prevention work so that we can support services. And we need to do this within the financial envelope that Helen's already talked to us. The NHS accounts for 40% of the UK tax bill. I should imagine we're all taxpayers here. I know I am. We're all taxpayers here. 40% of the tax bill. We can't keep asking for more. We need to spend what we have in a different and more effective way. And when you talk to members of the public, they sometimes say, well, you just need more money, don't you? You just need more nurses, or you just need more doctors. That's not the answer. There isn't the money for more nurses, more doctors. We don't have the workforce. We don't have the money. The economy doesn't have the money. So we've got to look at things differently. What's the timescales? Well, of course, everybody wants that. We want to do it today. Tomorrow, we want to make it better by Christmas. That's easier said than done. What we're doing is pulling together the data and reviewing what that data tells us, and helping us to see how we should do that differently and where we should concentrate, where we can focus. Because again, the temptation is to want to make it all different, all better, by a certain time scale. And again, within the resources and the money we have, we're not able to do that. So we have to focus on those big priorities and where we can concentrate. We need to do that not just with the clinical leaders who are leading this piece of work, but we need to do that with our wider clinical colleagues. We've talked about South West London, the population, the amount of providers, communities, GPs that we have across South West London. We need a collective body of all of those colleagues working together. And most importantly, we need you, our local communities, our populations, to work with us to be able to do that. This is a fantastic group of colleagues that I have the privilege to work with, some really esteemed colleagues. There's Elaine, the nurse on the end. We'll ignore her. We'll look at the rest of the colleagues. Many of you all know Dr. Nicola Jones, who's been working in South West London for some 30 years. She only looks 20, but she's actually been working here 30 odd years. She's a very experienced GP in Wandsworth and done a lot of work on prevention across the system and has been a senior leader in South West London for a long time. Dr. Andrew Murray, again, you will know he was the clinical chair of both Merton CCG and South West London CCG. He's one of the non-exec directors in one of our biggest provider trusts and is a practicing GP as well with a lot of expertise in system leadership and service redesign. Professor Stella Vig is one of our consultant colleagues at Croydon, a vascular surgeon, but she's also the Deputy National Medical Director for Secondary Care, has some real expertise in planned care and surgery. And Dr. Billy Boland, who's the Chief Medical Officer for South West London St George's Mental Health Trust, a consultant psychiatrist. He's the clinical director there. So we're trying to encapsulate all of that expertise for the whole of South West London. We're working together with colleagues looking at the data, kicking the tyres on that, which has been fascinating and interesting. Of course, the more data you see, the more questions that you have, and we've been working with that. But we've also gathered a significant number of clinical colleagues from across South West London in all the sectors to be able to support us with that work and work as we move forward. It's a really exciting piece of work to be involved in. It's really the right thing to do for the population of South West London, and I look forward to in the future being able to come back and telling you our progress. Thank you.
Thank you, Elaine and Katie and Helen. I'm sure you'll agree we've covered a huge amount of territory there in a relatively short period of time. So now's the opportunity for people to ask their questions. And I'm going to open it up to the floor in a moment. But before I do so, I'm going to suggest that we have some questions that were registered with us in advance. So I'll read those out and then ask a member of the team to respond to them, and then I'll come to people in the room. So the first one we have is from Tony Burton from Mitcham Cricket Green. And Tony asks, what are the implications of the current changes to the NHS for your plans to deliver the health and wellbeing hub at the Wilson in Mitcham? And what is the current expected opening date of the new facility? So, Mark, are you able to help us with that? Yes, go ahead.
Hello, everyone. I'm Mark Froman. I'm the place lead for Merton and Wandsworth. In terms of the Wilson, earlier this year, the ICB agreed for us to proceed to the business case and start working on the business case development. As part of that, we wanted to revisit the clinical case for change in East Merton, because actually previous plans were probably 10 years old, and whether it's digital or populations, we know things have changed in the borough. So we embarked on that with our public health colleagues as well as our clinicians to really try to assess the health needs that are in East Merton. Now that also includes the Rowlands Park development as well. We are then moving on to the kind of financial and economic case. Obviously, finances are challenged. We need to take that into consideration. But also we have the 10-year plan, we have the London target operating model, and we have the very exciting strategic plan that we have to make sure that all those factors combine into one coherent story. So that's where we're at. Now, I'm going to fudge in terms of the opening date, because what I don't want to do is I don't want to set a date and then fail against that date. I think that has happened too many times in the Wilson. But we certainly are anticipating that our business case is worked up this year, and previously it was indicated that it would be 2027, 2028 when we'd be looking to open the service.
Thank you very much. Mark, so the second question we've got is from Health Watch Richmond. And they ask, what will the board do to ensure that the patient's voice will be properly listened to and taken into account in future? Katie, can you start us off, and maybe Elaine might want to say a few words about it as well.
I can, thank you. And I'm really pleased that this question's come up. I know that there's been a high degree of disquiet over recent months about our response to the Model ICB blueprint and the slimming down of the board membership that we have for the ICB. And I just wanted to stress really importantly, the board membership is not a substitute for meaningful and sustained relationships of community engagement and involvement. So a board meeting, you know, we've had clear directive within the Model ICB blueprint to reduce the scale and size of the governance of the board. The strategic commissioning organisations will be much smaller organisations with a much clearer and tighter focus. However, our role as strategic commissioner means that it is never more important than it is now to ensure that all of our commissioning thinking, all of our commissioning plans are tested, all of our decisions are informed and heavily influenced by local stakeholders, whether they be citizens, individual citizens, communities, patients, voluntary sector organisations, partners in local government, or any statutory organisations. So our intent and ambition is to work even harder. I think we have a really strong foundation here in terms of the work that we have done to really meaningfully engage with different communities in a way that is beneficial and makes sense for them. But we just have an increasingly strengthened commitment to that. It isn't about a seat round a board table, whereas actually the board will be much slimmer and be much more focused in a smaller number of areas. But actually our desire and ambition, particularly around our clinically led strategic plan, is to have something that is meaningful, responds to this really urgent and pressing matter for South West London around addressing inequalities, addressing unexplained variation, delivering the best possible outcomes, delivering the best possible experience, narrowing that inequalities focus that we have at the moment, which is hugely unacceptable, and doing that within our means. We simply cannot do that without doing this in partnership with all of our stakeholders. And so our desire is more engagement, more meaningful shared decision making, not less. Did you want to add anything to that?
I don't think there's anything to add to that, Katie.
Elaine's telling me I always say a lot, so.
Katie, can you say how absolutely, but how people can get involved in looking at what that might look like practically? Because I imagine what's behind this concern is, well, I know where I come at the moment, there's a board meeting and I can raise an issue, so where would I go? Can you just say a little bit more the practicalities about how people can get involved in designing how that engagement might work in the future?
Sorry, I'm back on, that's fine. Well, we've got a session coming up actually in the next couple of weeks with voluntary sector partners to co-design that, because what I'm really interested in is not doing two people. So actually I'm really keen for this next phase of the work, particularly what Elaine was suggesting is actually once we've started to come the other side of the data crunching and data validation, how do people want to be involved? Because clearly everybody has a really valid and important perspective into how do we design these pathways in a way that is going to deliver on all those ambitions for South West Londoners. So I don't want to dodge it, Anne, but I don't want to predetermine the outcome of some meetings that we've got coming up in the next couple of weeks. We've had a great session, myself and Lucy, this morning with the collaborative of hospices, for example. They were extremely clear about how they want us to work with them moving forward, and I'm fully expecting the conversations to be really rich and diverse with our voluntary sector partners. Really, I meet already with the local authority chief execs every fortnight, so really, really keen to have that as an ongoing discussion about how we make these decisions together moving forward.
Thank you, Katie. The third question we've got is from Sharina Caulfield. I think Sharina might be with us. Yes, Sharina, thank you. And you've asked how South West London ICB assures the quality and safety of maternity services when providers do not follow national clinical guidance. Elaine.
Firstly, can I offer my condolences, and we're really, really sorry for the experience you had, and I mean that genuinely. That's not a platitude. I know that you've had conversations with the Trust, and certainly I'm very happy to have some further conversations with you outside of here without sharing your personal details. South West London ICB has a responsibility to ensure that all of the services we commission are safe and evidence-based and follow national guidance, and there are systems and assurances and processes in place to ensure that happens. When that doesn't happen because clinicians decide to use different clinical guidance, the Trust needs to be responsible for making sure that there's evidence base for that deviation. We know there is lots of learning that needs to happen, and we continue to work with the Trust and the system to do that learning and continue to strengthen our approach to quality and safety across the system, improving how we spot risks earlier, supporting more open conversations with our providers, and sharing that learning across the system, and that there's more work for us to continue to do with that. But I'm very happy to have a conversation with you.
Do you want to just use the microphone?
Yeah, thank you for giving that overview, but I'm really keen to have my specific question answered in the public forum. So what are the processes that the South West London ICB has to ensure that trusts do follow national guidance, or if they don't, that there's been some kind of quality assurance mechanism specifically?
So the trusts themselves have a responsibility to have a governance process if they deviate from national guidance. And sometimes clinicians will, so some of the national guidance is guidance, and some clinicians will have a different view on that guidance and whether they think that there's something that they can do then that can enhance the national guidance. It's up to the trusts themselves in their own statutory bodies to assure themselves that if their clinicians have deviated from that guidance, that there's been a governance process in terms of decision making, and that they can evidence why they're doing what they're doing, why they're deviating from that guidance, and how that's improved. It's up to the ICB then, in our current format, to assure ourselves that that process has happened.
And how does that take place?
So that takes place by regular meetings, by monitoring, by system learning, so in maternity services.
Maybe some context. My daughter Maya died a week after her due date last November at a trust in South West London, and MNSI, the National Investigation Programme into Baby Deaths, found that the trust had not followed national guidance in 9 areas of her care, and 8 of these had not been approved by the ICB, but one of those had. And so I'm really keen to understand very specifically how it can happen that a trust doesn't follow national guidance in 8 areas and does not follow in one area with the approval of the ICB. How can that happen?
Can I ask Masood to come in, who's the chair of our quality? So just to provide context, obviously, as Katie was saying, we have a board within South West London, and the board obviously has to receive assurance in a whole range of areas. And one of the ways that we do that on quality and safety issues is we have a quality committee, which is chaired by one of our non-executives, is a clinician by background, the role of that committee is to provide assurance to the board. So I wonder if it's helpful if the chair of that committee says a few words. Masood.
So I'm Dr. Masood Ahmed. I'm one of the non-executives, and I chair quality and performance. I wasn't expecting this question, and no. Just to give you some context. 27 years ago, I lost a child as well, and it was a cot death. And at that time, I was a junior doctor, and so I'm answering this because there's a personal understanding of the context, and that's part of the reason why, having gone through executive roles in the NHS, I'm now a non-executive, because I think there is a challenge for us as boards of what happens at a personal level and then how that works up. Now, specifically, what you've asked is what actually happens in a practical sense. One of the key things that is happening is how do you understand an incident, a single incident, but actually how do you extract the learning from that? And one of the things that is happening is a methodology called PSURF, and I can kind of go into that in a bit more detail, that's being rolled out across the NHS, where there is thematic learning. So part of it is when these things happen, how do you understand things at a thematic level rather than just a single incident? And how do you then implement that? So that is a methodology, because what you're asking is, what are the practical steps?
Sorry, just to clarify, my question isn't after an incident happens. My
Before.
question is that there is national guidance that is well disseminated, that trusts are advised to follow. They can diverge, but there should be some kind of quality assurance process before an incident happens.
Yeah.
So that is medically sound, and no one yet has answered what that is.
Okay. So there are a number of things that happen. One is the CQC, and that is.
Sorry, my question's about the
Yeah. So just to provide context, because again, when you're dealing with something like this, there are a number of people that have different roles, and our job is to, one, ensure that the governance is in place, so how the decision's made. The other is the assurance piece. How do we know at a system level that actually we're finding out these things? And part of that is the reporting, part of that is the data that comes through, part of that is the trends, part of that is the incidents. And so it's triangulating all of that to ensure that we can be proactive and go back to the trusts and say, hang on, things aren't quite working out.
So how does the ICB know if, thank you, how does the ICB know if trusts providing maternity services aren't following national guidance or following it diverging in a way that isn't medically sound?
So that's one of the indicators.
Yes, how precisely does the ICB do that?
When you talk about the guidelines, that's governance. The policy that are in place is the governance. And our job is to see whether they are, and we know that there is a challenge locally in maternity services. So it's not that we don't know, we do. And our role is to work with the trust to then ensure what are they doing to actually make sure that they are following the guidelines. So there is a process. We do get the reporting and then we work on that. And then I understand what you're saying. It is complex. There's no simple answer. And that's why I'm trying to explain that, when you've got these challenges, there is a lot of work that goes on in the background to move the needle so that actually they are following the guidelines. There's also other bodies that are involved that look at this, they do their visits, and then they make their recommendations, and then they come back to check that that's happening. It's clear from what you've said, and we are aware of these challenges, that there are problems that we are trying to solve. And I can pick this up with you afterwards because it's not an easy one, especially when you've gone through that and you've gone through what you have.
Well, thank you for your time, but I don't feel anyone here has answered the question specifically on what the processes are on the public record, and so I'm happy to leave it there, but I don't feel my question has been answered.
Let me try and bring it together, Sharina. So at a basic level, what the ICB does is it requests and receives. So the Commissioner has a contract with a provider, a hospital in South West London. Through that contract, the provider is required to provide us with data. That data set is designed to allow the type of inquiry that Masood is indicating. So it'd be a whole range of things that have been predetermined by the ICB, which essentially are things that will alert us to the fact that there's a problem. So, for example, serious incidents. So a death of a child would be flagged on the system, and that is a requirement of that provider to report that to its commissioner.
Yes, I understand that, but that data level is only at a very extreme level after things have gone incredibly wrong. What I'm talking about is policies, and these are kind of very subtle changes where it would, you know, statistically, only one extra baby would die every couple of years if providers weren't following, you know, the letter of national guidance. And so
Yeah.
it's really about the kind of level above outcome data. What is the trust doing to monitor that? What the actual policies are saying to the clinicians, and if
Well,
they match
yeah.
national guidance or not.
So there'll be a whole range of indicators. I mean, SIs is one, near miss is another.
Can you
know,
name
so
ones that are specifically about the policies, the local policies?
no, but I'm sure if you want us to write to you to set those out, what specific data points we would be looking at.
Yeah, I'd appreciate if you could do that publicly.
So I think that's
afterwards.
possibly what we
Sure.
could do
Yep.
to help you. But be assured that there is a flow of data that goes into the ICB. We have a quality committee which looks at that. So obviously you've got an executive team and a chief executive whose job it is to ensure the quality of services. But there is governance where you've got a committee that, if you like, provides assurance on that. I think what you're touching on is something which is a very important issue, which is that it is, as Elaine says, guidance. And it's not possible for the ICB to enforce that an individual clinician must follow it. And so inevitably, when it's not followed, and actually a better outcome would have come if they had followed it, we're going to be picking that up after the event, if that
Yeah, I'm
makes
talking about
sense.
local guidance where it is the trust guidance, not about individual practice decisions, where local trusts, two that I've looked into, have wildly diverging local policies compared to evidence-based national practice.
Have
Some
you
of
got an
which is
example
signed
of
up.
that?
Pardon?
Have you got an example? Which sort of policy are you thinking?
Yes, so MNSI, which is the National Maternity and Neonatal Safety Investigation, the programme by the UK government run out of the CQC, found that in Kingston Trust, in the death of my daughter, there were 9 divergences from national guidance, one of which was signed off and approved by the ICB, 8 of which weren't, which contributed to her avoidable death.
Yeah.
Many of which were
So
contained
you're-
in local pieces of policy. They've been in place for many months, if not years.
Yes, okay. So your specific question is, why did the ICB do that?
Well, how did it get to a position where the local trust was able to give care that was so wildly different from evidence-based national guidance, most of which it seemed the ICB had no idea about, and in one area it had approved,
Yeah.
going against the medical consensus.
So I think there's two things. I think we need to take that particular circumstance away in terms of that particular case, because I think there's two things we're talking about here. One is, do we have a systematic way where we assure what providers are doing, including them following national guidance? That's one area of your question. I think the second area is, and in this particular instance, your challenge to us is, and it wasn't just like one variation, there were 9 plus another one that was
I mean, it's
signed
both.
up by the ICB.
It's everyone who's receiving maternity care in South West London, particularly at 2 trusts that I'm concerned about, are receiving a lot of care that does diverge from evidence-based national guidance. And my understanding is that the ICB has a statutory duty to provide, to assure that the trusts are providing quality and improving care, and that doesn't seem to be
That's
happening.
correct, yeah. So I think, can I suggest that we have a meeting with you outside of here, and following that meeting we write to you with a written answer to your questions, because I don't think we can get into the detail of it today.
No, I was hoping for this overview of how you quality assure, but it seems that is, you know, more complex than you wish to talk about here, so that's fine.
Right, so I hope I've provided you with some overview, which is we have a board, we have a quality committee, we have certain standards to be met within contracts, data flows as a result of that, and we scrutinise it.
Mm-hmm.
Your question is,
Yeah, if that's the
how
level of
effective
detail
is
you
that?
can, well, no, I want the detail of it, but if that's not something you can provide in this forum, then yeah, we can pick it up.
Yeah, fine.
afterwards. Yeah, okay.
Okay, thank you very much. Thank you. Can I ask Katie, you'll follow that up? We'll follow that up with you outside of here. Okay, other questions from people? Yes, gentleman at the back here. Yeah.
Hi, my name's Bruno Meekings and I work as Community Involvement Manager for Richmond Council Voluntary Service. The question I'd like to ask follows up to some extent on the question which was raised by Healthwatch Richmond, and it's around co-production. It's something which isn't actually mentioned at all in the 10-year plan, the only talk of co-producing anything is in relation to the response to maternity services and the deaths of neonates. So I'm kind of very interested in understanding how the ICB is going to meet the requirements which exist outside of the 10-year plan around co-production, given that the VCSE Alliance is being dissolved with no further funding to it. Health watches will be abolished in the not too distant future, and it will become that much more difficult for the ICB to relate to people within its communities. Yet we know from the 1970s that that is absolutely necessary in the design and commissioning of services. So I'd like to know whether you're going to have a strategic plan around how you're going to implement your engagement and co-production, or what you're going to try and do about it.
Thank you very much. Katie, could you respond to that?
Yes, thank you for that question. And I think it builds on the answer I gave, as you say, to the Health Watch one, is that I don't want to sit here and say to you, right, well, we're going to do it this way, because actually that hasn't been through a discussion that we're having about what is the best way to do it. So as I say, we are having that conversation in a small number of weeks with our voluntary sector partners in the light of the changes that are being made about how should we do that. There are great examples across South West London where we have worked with particular communities or particularly voluntary sector partners to secure really meaningful engagement and co-production, either around service design or evaluation. So we will absolutely do that, and yes, will we codify that into a written document? Yes, we absolutely will, but the vehicle to do it is through the clinically led strategic plan, obviously. I alluded to the fact that the meeting I had with our hospice partners this morning, they were incredibly clear and robust with me about how they would like to engage in a meaningful way to co-produce pathways of care moving forward. I think we really, really welcomed that offer and have agreed a way of working moving forward. I am fully expecting that the conversations we have in the coming weeks with our voluntary sector partners, with Health Watch moving forward, we will agree the same things, which we will then absolutely write that down. Yeah. So this isn't about what's written in the 10-year plan, it's how we deliver the best outcomes, reduce inequalities, and live within our means for South West London. We have to do that together.
Yeah, thank you for that response. That's fine as far as it goes with the voluntary and community sector, which is a necessary and very valuable conduit towards communities. But also there's the question of people and individuals themselves, people who are affected by health inequalities, people who are affected by discrimination and you know, a lot of kind of other issues. So will you be producing any kind of expectations as to what they can expect in terms of their relationship with the ICB too, rather than just the kind of relationship with organisations which can reach them?
Yes, absolutely. We will absolutely set those expectations out and those ways of working. My reason for raising the issue around voluntary sector organisations is not simply about the organisations themselves, but just because we've learnt from many meaningful and successful engagements in the past that actually it's the organisations that represent those communities that actually are harder to reach quite often from a remote or perceived bureaucratic organisation, that actually we need to work with those organisations who have greater access to communities that absolutely need to drive the design of services moving forward. So yes, absolutely, but we'll make sure that we write that down.
Okay. Thank you for your question. Lady at the back here. Could you just wait for the microphone? Sure. Thanks so much.
Yes, my question is kind of similar in a way. It's about community engagement, and I hear you that AI and going from analog to digital is the way forward, and I hear you when you say young people don't want to talk to anybody on the phone. But I do wonder whether you've left out a section of the community which is the older people completely, because looking around this room I see posters. I don't see one showing an older person really. Maybe I've missed it, I don't know. As it goes, there are lots of older people that I work with. Sorry, I'm Saida Islam, and I'm from chair of Wandsworth Older People's Forum.
I see.
So some of our members, many of our members, are not digitally enabled. So they're struggling to make doctor's appointments. So there is no way they can do some of the things you'd like them to do. And I noticed that there are no written reports or anything of any sort. So how are those people going to know what has happened in the year? How will they find out? Because they're not digitally enabled. So what I'm saying is I think you've left a whole host of people behind. The other thing, I want to commend you on your highlighting that diversity is important and inequalities you picked up on. But it is also prejudicial and inequality if you ignore older people. So I just wonder, have I just missed something, or, you know, what's happening?
Yeah, okay. Who's best? Katie?
I'll start, and I'm sure Elaine will want to continue. So my apologies if I was trying to be brief in my conversation. It's intended to be a as well as rather than instead of. I hear you at a deeply personal level as the main carer of a very, very frail 89-year-old father who is absolutely not digitally enabled in any way, shape or form. So I agree completely, but my comment was intended to be as well as rather instead of. I know we have gone too far, and actually it's really difficult for some people in our population to be able to access information through digital routes. And indeed, actually, that isn't just solely about age, because I've met some of the most digitally mature octogenarians that exist around the patch, but equally I've met, you know, people who are far younger than that, like me, who are absolutely digitally incompetent. So, you know, what we need to have is a variety of ways of making sure that if the purpose and objective is to enhance access, to enable self-empowerment for people to be able to be in charge and take control of their health and how they want to interact with health service, then we need a variety of ways of doing that. I think your point around no physical reports is here. Normally, I think our experience is if we have a pile of paper reports, they're still here at the end, and actually we're keen to try and not produce paper if it's not warranted, but absolutely we can provide you know, paper versions in any form or you know, language that people would like to receive them in. So my intent was not to leave a whole section behind. That's not our intent. That's absolutely not in the practicality of the plan, but it's also to recognise that we need to be responsive for different ways that people want to interact with their health system moving forward to be able to maintain control in management of their health. Yeah, no, definitely not lost them.
I can tell you that from my experience, we've tried to work with NHS as much as we can, and we try to help the NHS by asking them to come and talk about vaccinations. We then found that actually older people needed extra help. We arranged this meeting in order to help you. But when I asked for printed material, they said, why don't you print them at home? I mean, the thing is, you have to recognize that someone like me who works with a voluntary-led organization has got a little bit of money on a shoestring. It's not fair to tell me to print these things in my printer at home. Maybe I don't have the resource to do that. Mm-hmm. Maybe I want to print leaflets for my conference instead. I don't know. But I have found in the last year, I must admit, I only took over as chair in the last year, people just look at me strangely if I ask for written material. And I think that has to change. And I think that, you know, when you do a presentation like that, you need to include older people. Because if you don't include them in your presentation, to me, it looks like you've left them out. Thank you.
Yes. So I think
we'll take it's really helpful feedback.
Point you've made there, and please take it that it was an omission. It wasn't that people don't understand the issue you raised. I think it's you've articulated it very well. Other questions? Yes, there's a gentleman here, and then I'll come to this lady. Yeah.
So how do you think this ICB's position for addressing health inequalities compares to ICBs in other parts of the country?
Oh, goodness. Don't know who's best placed to answer that. Do you want to have a go? You have a go.
Yes. So I think Elaine's looking to me to make a start. So the honest answer is I'm not going to speculate because I don't know. It's the answer. I know that we don't do well enough. I suspect that others don't do well enough either. But actually this changes for us now. So, I'm not trying to dodge your question, but I just wouldn't want to speculate or, high-five ourselves in a smug way and say we do so much better, but nor would I want to say we do much worse. But what I can say absolutely emphatically, based on what we know, is we don't do well enough. And it's absolutely at the heart of this piece of work that Elaine and her colleagues are leading, is that we will really, really tackle that as a way of driving improvement in outcomes for all South West Londoners, is a very specific and deliberate focus on narrowing that inequalities gap.
I think one of the things, it's an important point you raised, because actually in the national system, it's not something that's measured in comparatively against ICBs. How we perform on waiting lists and A&E performance is, but something as important as health inequalities isn't. The other point I'd add to that, of course, is that if you look at the thing in the health service that has the biggest impact on health inequalities, from a health service perspective, that would be primary care. And of course, South West London has, not uniformly, but when judged with other parts of London, the best performing primary care. Now that's a proxy for me saying I would expect that to influence better outcomes for people. So there's better access generally across South West London to primary care, for example, than you would see in other parts of London. That's not to say there aren't pockets in South West London where that's not true, but overall we're in a better position than lots of other parts of London, indeed, other parts of the country. Yes?
So I have got experience of other ICBs. During the pandemic, I was Chief Medical Officer of the Black Country, which is the second most deprived region in England. And then I'm also a board member at a mental health trust in a different ICB. A practical example is the EQIAs, so the quality impact assessments. One of the things we have done since I've been chair is we've revised and kind of updated the process so it's more robust. But also when we're planning strategically, it's not an afterthought. That's one of the things that I had noticed, one of the things that I've seen in the past, that you kind of do your business plan, you work out strategy, you look at whether you approve it, and then the afterthought is, have we done an EQIA? We've brought that into the process so it's thought about early on. And so when you're looking at a practical kind of step, that's been done and that's being embedded. And our teams are looking at that. And it's one of the questions the board members ask regularly when we're looking at plans or we're discussing strategies. Have we looked at inequalities?
Thank you, Masood. Yes, you've got a question.
We do actually have a health equity partnership group. Hello, just to say we do, I'm Catherine Herfman, I'm a Director of Health Improvement. We do have a health equity partnership group with partners including local public health and our voluntary sector. We do have a programme of work, we do have a work plan, we do look at health equity, including health inequalities, healthcare inequalities and inclusion health, and we do have a plan of work going forward. So the work is ongoing. So and the very key aim is we do monitor the whole time and we check. We've got a live Explorer data set that we check as we go along the changes, and we try and identify emerging things as well. So just to point out, there is a programme of work going on.
If I could just add, sorry, your question was about age as well. And one of the things is when we do these impact assessments, we look at the protected characteristics. So there are 9 of those, and one of those is age. And so, again, I would support that. I've done work around digital strategies and so on, and it's more sort of digital first, not digital only. So again, it's not forgotten because, as you say, not everyone, things don't often come to mind, which is why you have to have robust processes in place to ensure that, all of our population are covered.
Yeah, thank you. Yes.
Thank you. Sarah from the South West London Voluntary Sector Alliance. So we heard how important the voluntary sector is when it comes to digital inclusion, when it comes to health inequalities, when it comes to prevention, and we know how important these topics are in the NHS 10-year plan. My question kind of is on the back of Bruno's from Richmond CVS, and it was about thinking system-wide. There are a range of topics when it comes to your relationship with the voluntary sector that really needs to be addressed consistently and in a robust way. Commissioning, contracting is definitely one of them. We've got an issue across the system rather than in single boroughs that needs to be addressed. And so my question is, well, it's not really a question because I know you're meeting with the CEO leaders of the CVSs and what used to be the CEOs of the leadership group in a couple of weeks' time. What I would like to see out of that meeting is a practical commitment in true relationship with the voluntary sector in kind of discussing these topics in a way that will bring a systematic change rather than an ad hoc provider emergency type of solution that really doesn't help and affects the residents really more than anything else.
Yes, yeah. Do you want to comment on that? I mean, I think that would be our desire as well, that there's a true partnership as distinct from engagement on individual issues.
If I can go back to it. Yes, definitely a true partnership, but
yes.
I think we really need, as Bruno was saying, a plan. We need some practical steps going forward that guarantees that the intentions, the very good intention that at their strategic level actually can translate into actions at local place.
Yeah. So you want to see what practically it means, how it's going to work. Yeah. I think you've both made that. This gentleman here, yeah. You got a microphone? There you are. It's making its way to you.
Thank you very much. My name is Stephen Hick. I'm chair of Health Watch in Wandsworth. We know that Health Watch is going to be abolished, according to the government, but it'll take, nobody knows, but probably 18 months or so because it needs primary legislation. I wondered, and the functions of Health Watch are supposed to go into the NHS and local authorities respectively, which raises a whole pile of very important questions, including independence, which Health Watch and its predecessors have always had for the last 50 years, and a big question mark about marking in homework and so on. So I wondered, really, you talked about engagement with the voluntary sector in general terms. What plans you have to engage with Health Watch in terms of both managing the transition, because there's clearly risks in that, and the design of how those functions are going to operate? And in particular, are you also engaging with local authorities who, of course, commission Health Watch? So there's a big question which matters both materially about the future design of how this is all going to work, but also in the near term, giving staff and the people involved some assurance about their future so that they can make their own plans.
Yes. So your questions, I think, if I just pull out the two things that you're questioning, one is how will the transition work effectively, and secondly, how many conflict of interests might be.
Well, it's about the process, really. It's about the process going forward for engaging on these questions.
Yes. Okay.
Yeah. Thank you. I'm just trying to think of how I can answer this in a diplomatic and appropriate way. But let's just say it's quite fluid, isn't it, the way this policy is being applied at the moment, not only for Health Watch colleagues, but also for ICB colleagues. We're all slightly uncertain over what timeframes and what transition needs to look like about a variety of different statutory and legal requirements that each body is currently responsible for, or indeed the timelines around any changes required in primary legislation. So if that's the context in which we're operating, the commitment I can offer is that there is no change until everything changes. So our desire and ambition to ensure that we're held to account through the independence of what Health Watch with the decisions that we make in the intervening period are maintained, and I would like us to continue to have that conversation on an ongoing basis about how we work together to make sure that we collectively discharge those functions in transition. The issue around conflict, I mean, on one level, I could say, actually, there are so many potential conflicts of interest for all of us every time we come into work at the moment. It's how we manage those and call those out and just make sure we work effectively. I hear what you're saying entirely. it's an issue and conundrum we share around some of the functions that currently sit with ICBs that may be, for example, transferring into providers into the future. But it would be disingenuous for me to sit here and say, oh, well, here's the answer, and it's all fine, it's very straightforward, but we will have a commitment from us is that we'll work on it together, and until everything changes, we expect that our respective accountabilities still exist, and we will want to work meaningfully with you on an ongoing basis.
Thank you, Katie. Want to come back on that? It's just coming to you. Yeah, there you are.
Apologies, I've got a question from one of my colleagues. He was asking what will be done with the anti-racist approach report and how can we ensure that the ICB implements our recommendations. So this was John from the Kingston, I think it's called racial, sorry, I cannot quite remember the name of the organisation, but it's based in Kingston, and it was commissioned by the South West London ICB to do a piece of work around anti-racism in South West London. So they produced a report, and he wanted to know
what's the action
will be
plan
done with
associated
the recommendations.
With it? Yes, okay. Who's best placed to? Andreas, yep.
I think it's Kingston's Race and Equality Council, and John Azar is from him as the question.
Yes. Karen.
Thank you. Thanks for answering the question, Sarah. So we haven't actually received the full report yet, I don't think. So there was the last that we'd heard was there was a conference that was considering all of the actions. So as soon as we get that, we will then think about the actions, and we'll talk to John and others about how we take that forward. I think Melissa's been in touch with him. So yes, it's something that we are absolutely committed to do.
No. I mean, he did come and talk to our board. That was quite a while back, yeah. But I certainly haven't seen the report. So the request is once we do receive it, then to communicate what we're going to do about the action plan, the recommendations. Fine. Other questions? Yes, lady here.
Hi, I'm Dr. Ishta Govaya. I'm a scientist, a trainer, and an innovator. And I was really interested in a conversation about payer functions and resource allocation. I was wondering, for the multi-neighborhoods, the systems of organizations working together, how do we find out about which ones of them are already in existence, or which ones of them are being created? Is there a listing of these? Is there some way that we could figure out how to become part of these systems of organizations? So
the neighbourhoods you're talking about, yeah?
Yeah, whoever is contracting for the strategic commissioning.
Sure.
So there's a number of different things within that. Obviously, what I was referring to with the provider place-based alliances, they're not responsible for strategic commissioning, so they will essentially be responding to the intentions made by the strategic commissioners. So we will have 6 of those, one that is related and coterminous with each of our boroughs. We are just in the process of putting into place our chief officers for place, so we can circulate after this the names of those individuals. There's one, but that really importantly is they are coordinating the development of the provider alliances. So that's the provider bit. In terms of strategic payer functions, that sits with the ICB, and obviously we are still in the process of moving to what the model ICB blueprint says we should be doing around strategic commissioning. So it doesn't exist yet, but we are in the process throughout the remainder of this year and into the early part of next financial year, moving to those arrangements. But certainly we can, you know, for example, we've changed, we've finalised our new executive structure, so we can share that type of information. So you've got contacts of the executive leads in each of the areas, but we haven't got the structures that sit below those executives at the moment, because that's what's subject to a pause. I think that's how it's being described at the moment, whilst ongoing discussions happen between Treasury and the Department of Health and Social Care about how these changes will be funded. So sorry, I'm not trying to fudge the question, but there are people who are responsible to the ICB board for accelerating the development of provider-based alliances at place. We can share the names of those individuals, and then we can also share the new executive structure from the ICB, but we haven't moved fully to the new arrangements yet because, as I say, we're subject to a national pause, as to my earlier conversation about the policy is quite fluid.
Yeah.
Thank you. So in the meantime, what's being done in terms of strategic commissioning, for example, to move in the direction of addressing the population health inequalities?
So that's the piece of work that Elaine's been talking through, that we've all been talking through this afternoon in terms of the plan that we're in the process of developing. So we're in the early stages of that. You know, we're actually at the big data crunching, data validation exercise at the moment. So over the next 2 to 3 months, that work will be complete, and the clinical workshops that Elaine was talking about will be undertaken, but it's not complete yet. So it's very much work in progress.
Does that answer your question? Other questions? No? Yes?
If there are no more questions, this might be something that other people in the audience are wondering about. You've referred to the working with voluntary groups and partnerships and getting, as you quite rightly said, information about hidden groups of people that we don't know about. I wondered who are your voluntary partners, and whether you have somebody representing older people.
I don't know about that.
And whether you have somebody representing different ethnic communities. I don't know, I'm just asking.
Yes.
Who decides who's on that board, on that group? Thank you.
So sorry, which group are you talking about? Our board, do you mean?
No, the voluntary sector partnership,
okay.
Yeah. So the person who's absolutely best placed to answer this is the person with no voice, who has laryngitis. Because she sat behind you
Who's
unless
behind
she's moved. So maybe we can follow up in a written response afterwards.
Yeah.
Thank you.
Yeah. Yeah. Okay. Any other comments or questions that people want to, before we close? No? Well, it leaves me to say thank you very much for everybody coming. Thank you for your questions and your interest. The information that we've said we'll circulate, we'll get that round to people. And make sure if you want to receive it that you have registered and we've got your contact details. But thank you once again. And if you haven't had some of the refreshments, do help yourself. Thank you very much.